Welcome everyone to the SAB's March educational webinar, Goal Concordant Care for Patients with Advanced Cancer, part of the SAB's 2022 educational webinar series. Before we get started, I wanted to inform everyone that you all have joined in a listen-only mode. Please ask any questions throughout this webinar by using the drop-down tab labeled Questions on your control panel. We will address all the questions at the end of the lecture. At this time, I will hand it off to Dr. Ahmad, the SAB Chair of Education and Program Committee, who will introduce tonight's guest speaker. Thank you all for joining, and Dr. Ahmad, take it away.
Hello, everyone, and welcome again to our educational webinar. It is my pleasure today to introduce my good friend, Dr. Marcin Chwistek. Dr. Chwistek is the Director of Supportive Oncology and Palliative Care at Fox Chase Cancer Center, where he is a very treasured colleague. He's a professor within the Department of Hematology and Oncology as well. He's a fellow of the American Academy of Hospice and Palliative Medicine, and where he also serves as the editor-in-chief of their journal publication. He is also an associate editor for the Journal of Pain and Symptom Management. His research and clinical interests focus on cancer pain management, promotion of goal concordant care, and global palliative care. Dr. Chwistek has received many awards and has been recognized in many different arenas. A few of the selected awards include being selected for the Castle Connolly Medical Limited as a top doctor in cancer pain management ever since 2012. And in 2019, he also received the American Cancer Society Cancer Control Award. It is my pleasure to have him here with us today and share his expertise. Dr. Chwistek.
Thank you, Danish. I appreciate the invitation and welcome everyone. Good evening. I just wanted to talk to you today about the improvement of goal concordant care in patients with advanced cancer, which I hope is something that will be of interest to you. So here is just a few objectives for today. I wanted to talk about advanced care planning and how this is changing in the sort of modern landscape of oncology, but also recognize that goals of care conversations are an essential element of goal concordant care. We'll talk about communication as a bedrock of goal concordant care. And then I would like to just share with you a little bit about the initiative that we are doing at Fox Chase to improve goal concordant care for our patients. So let me start with the case of a patient that I recently took care of. It's a patient with a breast cancer, but it's not about her medical diagnosis. I would like to share her story with you and focus on the trajectory of her illness, which I think is applicable to many of the solid tumors this day. So Anne was 52-year-old female who was diagnosed with breast cancer in 2005. She underwent the standard treatment, neoadjuvant chemo and surgery and radiation, and then was on hormonal treatment. It did really well for basically 14 years until in 2019, developed some chest pain, was found to have sternal metastatic disease, and then soon after, a mass on her chest wall. Right after that, she started having some neurological symptoms that started initially as a pain in her lower extremities. There were some episodes of confusion, and then subsequently she was diagnosed with leptomeningeal disease, 2020. Her disease, she continued anti-cancer treatment, underwent radiation therapy, and continued to go through the treatment for the next almost 2 years. As you, of course, know, the leptomeningeal disease carries a very grim prognosis, but she really did relatively well. Although her course was quite complicated. She developed radiation pneumonitis. At some point, she became paraplegic. She developed steroid-induced diabetes. Her pain has been severe and required complex pain management. Just wanted to draw your attention to the fact that actually in her case, she received anti-cancer treatment for throughout all of this time, which is about 17 years, which I think is quite remarkable and not unusual these days. At the end of the 21, she enrolled in hospice, and then in January died at home on home hospice. We have been involved with her care since the 2019 when her disease recurred, and reviewing her case recently, I noticed that we had seen her almost 20 times, I believe, during this two-year period. So that was also some interesting to sort of see how her care evolved and the teams that have been engaged in her care. So a few highlights, very prolonged course of illness, almost 17 years of anti-cancer treatment, multiple care teams. She actually was treated here at Fox Chase in Philadelphia, but also at University of Pennsylvania, where she went for proton radiation therapy. Very high symptom burden, severe pain, multiple symptoms related to her cancer, requiring complex symptom management. High psychosocial distress, primarily related to the uncertainty of her prognosis. At the time when her bone, when she recurred in her bones, and then leptomeningeal disease, that this was difficult to process and figure out what the future holds. She outlived her diagnosis of leptomeningeal disease, and of the usual prognosis associated with it, and lived for 18 months is the time of the diagnosis, which I think is quite remarkable. Also very high caregiving burden. So her husband was her main caregiver. He actually quit his job to be able to continue to care for her. He had to buy a wheelchair accessible van to be able to get her out of the house. There were many family members and friends who were involved in her care. She was very involved in her local community. But what I think was remarkable was really the complex decision-making in her case. Things like how to address her leptomeningeal disease, when to enroll in hospice, what does it mean if she enrolls in hospice, whether to continue or not to continue her oral anti-cancer treatment, and many others. So, we're talking about Gold Concordant today, and the question is, was Anne's care Gold Concordant, and what does that mean? Gold Concordant care has been defined as care that is aligned with the patient's values and priorities. There is no one way to determine whether someone's care was Gold Concordant, and there's no simple way of doing this. Most of the time, when we ask family members, they will say yes, and they unfortunately are sort of biased in their view, maybe biased. We can't ask the patient, so it's really hard to determine. But looking at it from my perspective as an outsider, I think it was, but we'll sort of discuss this in a little bit more detail. Gold Concordant care has really emerged as a model of care that values patients, that honors patients' values, priorities, and preferences. And it's a sort of a mouthful when you think about this, but we can be simply expressed as this statement that really it is what matters to our patients matters to us. When you think deeply, though, about this, for us to be able to deliver the care that is aligned with patients' values, we really do need to know what matters to our patients. And in order to know what matters to our patients, we need to have a good communication with them, and then shape the care that they receive in a way that is aligned with those values and priorities. Gold Concordant has been recognized as an indicator of high quality care. It's been supported by patients, caregivers, clinicians, healthcare systems, and payers, identified as a key priority by the National Academy of Medicine, and then also rated by an expert panel as the most important outcome measure for studies of advanced care planning interventions. So let's go back to Anne's case. So we talked about her trajectory, we talked about her treatment and our team's involvement. Anne was someone who worked as a paralegal, and she was the most organized person I've known. She had advanced care planning completed in 2005 at the time of her diagnosis, and then revised again in 2019. But I would argue that it wasn't the advanced care planning that allowed her to receive the care the way she did, and I believe the care that was aligned with her wishes and priorities. It really was the goals of care conversations that we've had throughout that period, multiple of those conversations, or you can think of this as a one conversation that has taken many reiterations over the months. I think advanced care planning is very important, and it helps us to determine the healthcare proxies and maybe some preferences in regarding to end of life care. But given the landscape of oncology today and the prolonged course of treatment, even for patients with advanced disease like ANS, it's impossible to predict things, and it's impossible to shape someone's care based on advanced care planning, and that's why the importance of goals of care conversations. There are, another description for it are those kind of discussions that happen in the moment. So how do we get there? How do we make sure that the care that we deliver is goal concordant? It is a somewhat windy road, and it's not an easy process, but I think we're making some progress in terms of figuring this out. So just wanted to share with you some of those things. But first, the historical perspective. So advanced care planning came to be in 1990 as a patient self-determination act. And that act requires that all healthcare facilities receiving reimbursement from Medicare or Medicaid ask patients whether they have advanced care directives to provide information about this and to incorporate advanced directives into the medical record. As you know, this has not really been very helpful. It leads to many situations when this is becoming just checking of a box. A colleague of mine said that recently she took an infant for an exam under anesthesia and was asked about the advanced directive. So, it's really quite useless in those kind of situations, and I think unfortunately has not fulfilled the role that we were hoping you would. In 2017, there was a publication that sort of tried to determine the definition for advanced care planning. I think there's still a lot of confusion about it, what it really means. But the authors here define it as a process that supports adults at any stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And I think that's the key. The purpose really of the advanced care planning is to ensure goal concordant care near the end of life for patients who lack the decisional capacity. It also helps to choose and prepare a trusted person to make those medical decisions and sort of document the wishes that can be carried out. But of course, as we discuss, there's a lot of ifs and a lot of problems with this approach. And actually, when we look at the statistics, despite all the efforts since the act took place, still about 50% of adults, 1/3 has documented wishes, and about 10 to 20% only have discussed them with their clinicians. The ACP engagement among racial and ethnic minorities is even smaller, only about 20%. And those disparities persist for LGBT, homeless, and incarcerated populations. So despite all those efforts, we have not really been doing well in this aspect. Well, what is the evidence whether the advanced care planning works? So there's been multiple studies published recently. In 2018 review, showed there is no evidence that advanced care planning was associated with influencing medical decision-making at the end of life, enhancing the likelihood of goal concordant care, or improving patients' or families' perceptions of the quality of care received. 2020 scoping review showed no link between advanced care planning and occurrence of goal concordant care or patient quality of life. Another one showed no association of advanced care planning with subsequent healthcare use, including emergency department visits, hospitalizations, and critical care. And then recently, 5 large multi-site randomized clinical trials could not identify meaningful differences in healthcare use, patient quality of life, goal concordant care between those randomly assigned to receive either advanced care planning or usual care. So the evidence is pretty significant. And then you might have seen that JAMA recently published an editorial viewpoint that was co-authored by 3 palliative care physicians who have been doing this type of work for a really long time. And it was entitled, "What's Wrong with Advanced Care Planning?" And basically, they say that advanced care planning does not improve end-of-life care, nor does its documentation serve as a reliable and valid quality indicator of end-of-life discussions. They also go on to say there were almost 2,000 studies done on advanced care planning and millions of dollars were spent on conducting those trials. It clearly shows that we haven't made much of progress. So it really calls for a different approach. They also say that despite the intrinsic logic of advanced care planning, the evidence suggests it does not have the desired effect. Many clinicians may be disappointed that promoting conversation with patients well in advance of needed medical decision has not improved subsequent care as hoped. So why is this? And I think, for all of us who have those kind of discussions with patients, it becomes pretty clear that the treatment choices near the end of life are never simple, consistent, logical, or linear, and predictable, but oftentimes complex, uncertain, emotionally laden, and fluid. They are rarely static. Patients' preferences change, and they're influenced by their age, physical and cognitive function, culture, family preferences. It's really difficult to extrapolate from hypothetical discussion with patients that occurred in the past. Most of the time, those discussions, the advanced care planning are poorly documented. If you're lucky if you're able to find it in the chart, and even if it's in the chart, it really does not help you with the in-the-moment decision making. Surrogates really have a hard time often, extrapolating from those documents. And then we shouldn't forget that there are some financial pressures, institutional cultures, and practice patterns that really affect how we interpret and how we read this advanced care planning. So there has been a shift from advanced care planning to more something that we call goals of care conversations or Shields illness communication. That has a better promise of helping us shape the care of the patients with advanced cancer in the way that it's really aligned with their values and preferences. This type of communication focuses on the patient's current illness experience. It occurs with a trusted clinician who understands the medical aspects of the serious illness and can talk to the patient about the illness as well as its effects and meaning. And can discuss prognosis with empathy and in a patient and family-centered manner. And I think that would really differentiate those in-the-moment serious illness discussions, goals of care discussions from the advanced care planning. What it seems to be, the key in those type of discussions, I think, is the communication of prognosis. And we certainly see that in our setting here at our cancer center, that I think it is key to all of those discussions is the patients and families' understanding of their prognosis, which not always is simple, and choosing the right words is critical here. We often, when communicating prognosis, we ask patients what is their understanding of where they are with their illness. We also ask about their preferences, how much information and in what way would they like to receive. And then oftentimes have to also ask for the permission to share the understanding of how things are with their illness. And there is really art to communicating prognosis. The language can be tricky. It requires really a finesse and skill to choose the language depending on how much explicit discussion the patient can tolerate. But words have really different potencies like medications, and we can kind of dose this. But I think it does take some skill to be able to do it in a way that the patient can internalize the prognosis and really based on this make their decisions. I'm sorry. So here are some examples of language that we use while communicating prognosis. And when we're talking about this, and I just listed those, not as a means to be, providing you with all those possible ways of doing this, but just listing some examples. For example, you could say that if time were short, would you be doing anything differently? And I think that's a really good question to have as that really frames the problem a little bit differently and forces the patient to think, to kind of a step back from the reality of day to day and start thinking about the big picture. We can use what we call the worry statements. For example, I'm worried your body is telling you that the time is shorter than any of us hope. We can sort of acknowledge the unpredictability and the uncertainty of the situation by saying it can be difficult to predict what will happen with your illness. I hope you will continue to live well for a long time, but I'm worried. And again, the worry statement, you could get sick quickly. And another example of this is I hope that it's not the case, but I'm worried that this may be as strong as you will feel, and things are likely to get more difficult. So those are different ways of sort of approaching the problem, judging the reaction of the patient, of the family, and then choosing the right response. So just to put things in perspective, this is a conceptual model of goals of care discussion. It starts with the listening of the patient's values and priorities. And again, it requires good communication skills to be able to elicit those values and priorities. Sometimes patients don't know what they are exactly. And those need to be sort of established in the clinical context and then used to guide decision-making about the use of or the limitations on specific medical interventions. So that's sort of how we think about it. And oftentimes those goals of care need to happen many times over a period of time. And sometimes you make a little bit of progress and have to build on it at the time of the next discussion. But I think it allows us to have the conversation as the patients move through their experience of illness. And as we talked before, this is often a very dynamic process, which changes over time. So here at Fox Chase, we have embarked recently on improving goal concordant initiative. There is our vision for this is that all patients with cancer and their families receive care that aligns with their values and priorities. And we hope that providing such care will reduce suffering, improve the experience of the illness for the patients, and measurably enhance the lives of patients and families throughout the course of cancer. There was an editorial published recently that is actually co-authored by CEOs of the 10 cancer centers under the auspices of Alliance of Dedicated Cancer Centers. They talk about improving goal concordant care. And I think this is a testament to the importance of the initiative and the fact that the cancer centers are recognizing this as a priority. So the aim of the initiative is really that as we are thinking about the vision is that all patients with cancer should receive that kind of care, but the aim is that patients with life-limited expectancy should have high quality, timely goals of care discussions that are documented in the electronic health records. So how to do it from a more practical point of view? There's really, 4 essential elements to, I think, improving goal concordant care in healthcare institutions. Number 1 is the formal communication skills training, because I think all of us can get better at this. Most of us were not taught communication skills, and all of us can get better at this as we practice. So it's a sort of one of the skills that we practice throughout our professional lives. But talking to patients about it is not enough if we don't document those discussions in a way that can be easily discovered by others. And oncology, especially these days, is a specialty that is team-based, and there are multiple teams involved in anyone's care. So the teams need to be able to look things up quickly and know what others have discussed previously and be able to sort of communicate. So having a dedicated structure within the electronic health records for documentation of those care discussions is essential. You know, another aspect of this is that, you know, as much as we know when we see a patient in front of us, whether this patient has advanced illness and whether you know, they will or will not do well, most of the time we can tell this. It's really I think what we really need is a systematic approach to this. You know, how do we identify those patients in electronic health records to make sure that all of those patients have those kind of discussions documented? So, you know, we talk about priority populations, meaning how do we define those patients populations? And there are many centers that are using actually artificial intelligence and nowadays and build their own mortality predictors and develop new ways of looking at charts using natural language processing, for example, to try to identify those patients ahead of time and in some way flag their chart. So then when they come and see clinicians, they can be alerted, the clinicians can be alerted and make sure that they do document and start having those discussions with patients and families. So just a few words about the communication training. I think it's crucial, and we have actually partnered with a company that's called VitalTalk. You may have heard about this before. It's a nonprofit that was funded by 3 physicians, an oncologist and 2 palliative care physicians. The company was started with the NCI-funded research, and really their experience, they have experience working with multiple different healthcare organizations, from tertiary medical centers to cancer centers and community-based facilities. What I think makes them different is their didactics. Again, those are based on empirical research to deliver it in ways of teaching communication that really works well. They actually, in fact, hire professional actors and have developed scenarios that can be tailored to the clinical situations. So, for example, for us, it's all oncology based. So real people across different platforms. The training now, the basic training is condensed to 2 half days. So I think it can be relatively easily incorporated into a busy clinician's day. So that's something that I think we all have benefited from, and actually our plan here at FoxChase is to provide it to most, if not all, of the clinicians taking care of patients with advanced illness. And this is just a list of institutions that have partnered with VitalTalk. They also have a mobile app. There's a free version of it available, so I would encourage you to look it up. It's called VitalTalk, and something that it is actually easy to use. You could use it in the clinic for some of those more difficult communication scenarios. So in summary, really, I just wanted to talk today about the goal concordant care, because I strongly believe it is an indicator of high quality care, and I think this is we all should be striving to provide care that is better aligned with the patient's values and wishes. And today's complex and somewhat unpredictable landscape of oncology, it's not always easy and straightforward. And those kind of decisions really guide our decisions about medical interventions. And only by having often discussions with patients and families, we are able to fine-tune the care that they're receiving that best aligns with what matters to the patients the most. And again, effective communication is really the bedrock of successful goals of care conversations. So I'll stop here and see if there are any questions or comments.
Thanks, Marcin. That was great. Really appreciated that talk. A couple of questions here. One of the things that I found really really enlightening was how you talked about different goals of care conversations over a period of time, or maybe one goals of care conversation that is split up over a period of time. So how do you think those conversations change over time as our patients' illness gets worse and their prognosis is more and more limited? Do you have a different manner in which you approach them initially and compared to when you approach them towards the end of life?
Yeah, no, that's a great question. I think and yes, I think that that's one thing that I learned over the years is that you really don't have to have those, and ideally, actually, you don't have this conversation in one setting because it's clearly overwhelming, right? So the best way I think to do it, and again, it's the best way in my opinion, and the way that sort of I incorporate into my practice, is to do it over time. And once you build trust with the patients and families, and in our case, when I'm working with oncology patients, I'm not their primary attending. It's, the patients are being taken care of by their oncologist or surgeon. So I'm coming to it as an outsider. So oftentimes being able to take care of patients' symptoms and pain and allows us to build trust. And once we have that trust, then we can sort of start talking about things and exploring them. And again, you get to know the patients, you get to know their families, you get to know their style of communication or how much information they want. And then over time, I think you can elicit, gradually, what really matters, what are their values, and then sort of help them make those decisions. So I think, one thing about those goals of care conversation is that you kind of build on their previous conversations, and they can change, right? The things change. It's really dynamic. The clinical picture changes. I think it's really good when you think about the trajectory of the typical cancer patient with and we're not talking about patients who are being treated with the curative intent. That's a little bit different. But we're talking about patients who we know not going to do well, right? They may have metastatic disease or recurrent disease. They know they probably going to at a certain point die from this disease. They're not curable. But there's always a period of time when there's a relative stability. Before, when you look at the sort of function versus time graph that everyone is familiar with in cancer, you have this period of stability. And I think this is the best time to have those conversations before things start getting worse, before patients sort of fall off the cliff, right? And they have this really rapid deterioration. So before that happens, so getting to know them, getting to understand them better, what matters to them, I think this is what's crucial. And another element to this is, and I will stop in a second, is really documenting it. So that way you yourself can refer to what was discussed before, but also someone coming to the care of the patient who may not be familiar with it can look up any one of our notes and see, okay, this is what was discussed, a month ago or 3 weeks ago, and can build on this. He doesn't have to start from zero, which oftentimes nowadays is really very hard to find in the chart.
One of the questions that is listed that one of the attendees had was, how does your approach change when you're having this conversation in the hospital when the family member is acutely sick versus when you're having them in an outpatient clinic setting when the patient themselves can participate in this discussion?
So the question is about how the setting makes it different between the inpatient and outpatient. Right. And I think, ideally in those kinds, that's why the importance of this initiative is to have those discussions before the crisis happens, because I think ideally we would have, especially with cancer patients, we will have those discussions outpatient before they end up in the hospital for whatever brought them there, because I think it's a lot easier to do it over a period of time before the crisis. So it's a very different discussion when it happens in the clinic in a period of relative stability versus in acute setting when someone is deteriorating. And that's very difficult because it depends on how much trust or relationship you have with the patient. If you are that primary attending taking care of the patient, then it's a little bit maybe easier because you can refer back to the shared time and experience. But if you're a new person coming in, it's always difficult. And I always, when we do it oftentimes, but it's always challenging because again, you are seen as an outsider, someone who does not have the relationship with the patient and the family, and then you're coming in with bad news. So that's a really tough situation to be in. But I think starting where the patients are, I think the first step is really understanding what they understand. How oftentimes do we assume that the patient has a clear picture of what's going on, and they don't. And then it happens like all the time. I think medicine is really complex these days. It's really hard to understand everything that's happening. So I always start with, eliciting patients' understanding of where they are and what's happening in this moment, and only then trying to negotiate a common ground of understanding of where we are. And then it's not really about, changing someone's code status, or it's not about whether, it's more about, okay, this is what the reality is. What are your wishes? How do you want to spend whatever time is left? In what's important to you, and how can we help you make these decisions that will bring us there? And it could be that someone will say, well, I want to live for as long as I want to, no matter what. And that's the one type of a response, right? And then you do what seems to be right. Or someone else might say, no, I would rather be at home. I really don't want to be in a hospital. If I'm going to die, I would rather die at home. Not everyone wants this. So again, no right or wrong answers. It's just trying to figure out what's the most important thing as we sort of understand where the patient is and what the prognosis is. That's why, I was trying to sort of convey the idea of how important it is to convey the prognostic information. And sometimes, especially with oncology and my medical oncology colleagues, who oftentimes do a wonderful job, but they get stuck on talking with patients about treatment lines and treatment options. And I think that doesn't always register with patients. Yes, it's an important piece of information, but it's not really communicating prognosis. It's very hard for patients to internalize this if you're talking in abstract ideas of lines of treatments.
This is an interesting question. Going off what you just mentioned, one of the questions is, how do you offer support for clinicians and patients who may have discordant goals? There are clinicians whose philosophy is never to give up and continue to offer therapies, which may be third line, fourth line, or whatnot, and may lead to unnecessary hospitalizations or procedures. And there are oftentimes patients are afraid to contact their providers, and how best to approach those scenarios.
Yeah, it's a tough one. So and I'm assuming that you sort of are entering this conversation when there is someone else who is sort of pushing for more treatment, and
yeah,
and you are the third party in a sense, and yeah, so you kind of almost have to negotiate again the common understanding in all of those parties, right? And I think that's what's so challenging. And yes, there are and I don't think there's right or wrong way of doing this, or one way of doing this. I again try to bring everyone on the same page. And I think it helps to have conversation about what's happening right now and what is everyone's understanding. And also having direct conversations. We can't forget about the patient if they are able to speak for themselves or their family, and trying to understand what really matters to them. And then convincing or talking with other doctors about, how whatever we are offering, is in alignment or is not in alignment with what the patients want. It's a lot of diplomacy, that happens in those kind of situations, and not always easy, because again, it all depends on the relationships, right? So we might be the ones who really don't have that much relationship with the patient or family, as opposed to the primary attending. And it is a very super difficult situation, and morally distressing oftentimes.
One of the things that I found really interesting was when you talk about how advanced care planning and goals of care has not worked over time, and there are numerous studies that have supported that. And now we have moved towards a paradigm of serious illness communication. I was wondering if there was data about serious illness communication, and if that has proven to be more effective.
So there is some data coming out, but it's a good question. I think one of the difficulties with the data is it's super hard to actually do those kind of studies. And the holy grail of goal concordant care, people argue about what that is. Some say that this is actually the evidence for good communication. but yes, it's very hard to do studies. There have been some that coming out of the Dana-Farber group. They have published several that show that actually patients who've had the serious illness conversation had less anxiety, less depression. But it's very hard to assess the goal concordance because, you know, once the patients die, who do you ask? Families are probably not the best source of objective information. So it's been difficult. But it seems like we're moving in that direction. And it seems like clearly there's very strong evidence to show that advanced care planning, not that it doesn't work, but it doesn't work when it comes to, you know, making the decision ahead of time for the clinical scenarios that are unpredictable, and especially unpredictable today. It's just, you know, whatever you decide, and oftentimes, you know, we have those kind of hypothetical scenarios described in advanced care planning that have very little to do with the day-to-day decision making. And I think that's why the shift to more of a in-the-moment discussions seems to work better.
No, I think that makes a lot of sense. And I think that's a good place for us to stop. I don't have any, I'll pause to see if there are any more questions, but I'll take this opportunity again to thank you very much to join us and share your expertise. I know this is something that I struggle with whenever I'm in the ICU and even when I'm seeing patients on the floor in the clinic setting. So I really do appreciate the expertise you provide for all our patients, and I appreciate the time you took to chat with us today.
No, my pleasure. Thank you very much for the invitation. And I think, you know, one thought at the end of it is I think we all have to take care of ourselves. You know, this is hard work and hard emotional labor of taking care of very sick patients. And I think it is important that we sort of check in with ourselves as well as we go through this process, or talk to your colleagues. I think this is really important. So thank you again for the opportunity.
Thank you again, and you have a good night.
Thank you everyone for joining tonight's webinar, and we look forward to seeing you all at our future SAB educational webinars. Good night.